Thank you, Richard. That was an excellent summary of all of the radiotherapy literature for those of us who are not quite so up to date with it. We've got quite a few questions coming in from the audience. The first one from Nancy Gilliam, who's had 2 rounds of radiation therapy herself, and wonders what the research tells about the duration of treatment. So some of those studies did have fairly long follow-up. How long can you expect these effects to last?
Well, the data that I presented of primary radiotherapy, there are various follow-ups, and certainly the BETS trial goes up to 13 years. And the trouble is you can't look at different trials and sort of extrapolate between them. But I would say if you look at the sort of entirety of the data, then there's good long-term data with good control of early progressive Dupuytren's disease. And for those patients who have stable disease by 5, 8, 10 years, that seems to still be there by 13 years. So, if you say that 80% of patients don't get progression by 8.5 years, then in the BETS retrospective study, I think it was something like 65 to 70% still didn't have progression at that point. So there's a pretty good duration, at that point. I mean, of course, no one says it's a cure, but even if you delay it for quite a number of years, then that seems to be a result worth going for.
Quite. Okay. Lisa Lichtenstein wants to know about the variation in treatment area. So some radiation oncologists will go up to the PIP joint, others will stick to the palm or do the entire palm. Is there any evidence around that, or is this just individual practice?
I think that's a great question. So I think it's fair to say that there's a lot of variation, but ultimately we're trying to treat the palmar fascia, and so if you start going down towards the wrist, then of course it's very unlikely you're going to get disease there. And similarly, if you go past the DIP joint, then really it's very again very unlikely that's going to have a good effect. And most likely they'll lose sweat on the finger pads, and they may well have an effect on the nail bases as well with some nail distortion. So, so for me, I would tend to treat, I mean, roughly, if you can see my hand, up to about here. We try to miss out the thenar and hypothenar muscles. We tend to treat otherwise all of the palm. We would go to the PIP joints unless there's clearly disease going up there or a little past it, in which case sometimes I would go up to the DIP joints, but no further. So that would be my general sort of rule. Now, if you have disease, let's say you've got a nodule and a cord on the 4th ray only, then one could argue that you don't need to treat the whole hand that way. And so, for some patients, I'll add a couple of centimeters all around, being more generous toward sort of craniocaudally than I am laterally. So, outlining all the disease that you can feel, paying special attention, because sometimes the cords aren't that easy to palpate. And sometimes if you get them to put their fingers backwards, you can see a sort of white cord like that, or you can feel some roughness. So these things can be a little bit tricky to palpate. But feeling all the disease that you can, adding a suitable margin, but recognizing there are some sort of no-go type zones, like the distal phalanx, and similarly to going too proximally.
Yeah, and just in the chat, I noticed Professor Siegenschmidt is here and has said that these are forbidden zones for radiotherapy, no nails and no muscle areas, because obviously the side effects there would be too bad. Cindy Truscott is asking about insurance coverage in the US. I know we do have some US surgeons here. I wonder if any of them would like to make a comment. I don't know about insurance coverage in the US. But she's now alluding to Lederhosen disease. How do you tell the difference between Lederhosen and plantar fasciitis when you're counseling people for radiotherapy?
Okay, well, very simply, Lederhosen disease, of course, is basically Dupatrons at the feet, so you get nodules. Sometimes you get a syndrome which seems like it's plantar fasciitis to, let's say, the family doctor, and then you palpate and you feel some nodularity. So, you know, sometimes the nodules can be terribly tender, but not very big. I actually think, you know, if you get a patient with plantar fasciitis and they've got Dupuytren disease on their hands, you know, you've got to be very suspicious that there may well be fibrometer on the feet. And, you know, if that's the case, rather than just treating them with a lower dose for plantar fasciitis, because for an anti-inflammatory effect, you would tend to use a much lower dose, I would tend to think about whether we need an ultrasound or an MRI scan to see if there are fibrometer there. And if there are, I would tend to use the full dose for Lederhosen. So, you know, clinically, it can be distinguishable, but if it isn't, and they've got Dupuytren disease or perhaps a fibroma on the other foot, I would tend to want to get some imaging sometimes.
Okay, Paul.
Yeah. Thanks, Richard, for a great talk. I was just thinking a little bit about the field that you apply the radiation to. We all know that Dupuytren primarily affects the ring finger and the little finger, and not so much, and only in the most aggressive cases, the thumb and the index and the middle. And I wonder, why should you irradiate the fingers that usually are not affected at the start? Why not only keep to the most vulnerable areas as far as Dupuytren is concerned?
So what I find is, by the time I've outlined everything that I can feel, and I would include all the digital disease, and actually when I go looking, often I can find some digital nodules. So by the time I've done that and added a couple of centimeters around, I tend to find that a fair amount of the palm is covered anyway. If there's anything at the base of the finger, then I'll go up to the PIP joint. If there's nothing at the base of the finger and no disease on that ray, then absolutely I will miss out that finger. So I won't treat that finger unless there's something that seems to be threatening the finger. But in some ways, you know, I feel that if you miss the chance to treat that area and then you get a recurrence outside, you know, a centimeter outside what you've done, then you really have missed a chance. So I think, you know, it is a balance, and I guess, you know, I do take each patient as an individual, so I absolutely don't cover the whole hands in every patient. It is a very personalized and individualized treatment for me.
Yeah, for us as surgeons, the most difficult part to retreat is actually the part of the proximal phalanx area, from here to here, I would say, and then obviously little finger, ring finger. So I think that should be the main goal of radiotherapy if you want to balance harm versus benefit. What do you think about that?
Well, again, you know, you're right, this is a balance. And, you know, I think if there is disease that goes up to the PIP joint, then absolutely I'll take it one joint further. So, you know, I absolutely won't skimp, you know, just as you said in your previous question, we don't want to overdo it. You know, similarly, we don't want to underdo it. So, you know, I think the general rules are, if there's disease at the base of the finger, go up to the PIP. If there's disease going up to the PIP, go up to the DIP. If there's no disease at the base of the finger, I don't treat any of that finger. So, you know, one could argue, I guess implied by your second question, that you should treat further to the DIP joints on all the things you're treating. And, you know, I think that's a not unreasonable point. But that tends to be my practice.
Thank you. I think that answered one of our typed questions as well. There's a question from Gregor Sianos about how progression of disease was defined. So it seemed to be mostly about angular contracture or progression to surgery. Is that correct? So
in the study, the postoperative study, and also the primary radiotherapy study by Siegenschmidt et al., it was defined as quite a number of factors. So the primary endpoint of progression was more than 10 degrees increase in contracture, increase in the size of nodules and cords, increase in the number of nodules and cords. And so it was actually a very wide definition, which is actually why I then sort of focused down on what perhaps be a more accepted definition of 20 degrees increase in contracture, which I thought was perhaps more relevant in terms of you know, a sort of hard surgical outcome.
Yeah, it certainly allows you to compare a little bit to the surgical studies, which traditionally have looked at angular contracture really as as one of the outcomes. Our next webinar, just out of interest, I'm going to make a plug for that now, is all about measurement of outcomes, which I think is quite an interesting topic within Dupatrons as well, whether angular contracture is the right thing to measure or not. From a patient perspective, often I think it isn't, but we've got a whole webinar on that coming up. Paul.
Yeah, one little comment about angular contracture measurements already now. Obviously, some studies, and the 20 degrees comes out of a Delphi study, and that is talking about the increase in angulation of a single joint. Some other studies, like the studies of ourselves, looked at total passive extension deficit. So we summed up what happened at all joints. And it's important to make that distinction, because otherwise you're comparing apples and pears.
Yeah, quite. We'll discuss such things more next week, I think, or in 2 weeks' time, I should say. A shout out from Lisa Fondelius. Is there anyone from Sweden here who knows whether radiotherapy is offered in Sweden? Richard, do you happen to know that? Or if not, if someone could type in the chat whether radiotherapy is offered in Sweden for Dupatrons?
I don't know, but what I would suggest is that anyone who wants to know about where radiotherapy is provided goes to, there's a British Dupuytren Society Facebook group. And there's also another one called DART, D-A-R-T. And both of those hold sort of worldwide lists of radiation oncologists. So that will be a really good place to start. Fantastic.
Thank you very much for that. There's a question about Raynaud's syndrome. So Bonnie Reishus has had radiation treatment, but feels that her Raynaud's has got worse. Is that a known side effect of radiotherapy?
Well, there are certain connective tissue diseases that make one more radiosensitive. So if Raynaud's syndrome was part of a connective tissue disease, then I guess that would be a conceivable link. But Raynaud's disease in and of itself is not a contraindication.
Okay, thank you. This really, I think, maybe is a question for Paul. Amy Weiss says, with such excellent and documented results, why do most surgeons still dismiss radiotherapy as a treatment for Dupatrons? Paul, what do you think?
Yeah, well, in my country, it's not only the surgeons that dismiss it, but also the insurance companies. And the prime reason is that it is judged that the evidence, the scientific evidence, is not very strong, because there are no randomized controlled trials. That is why we are so happy that the group in Australia, headed by Jared Martin, who will give the next presentation, is actually just doing that. He's doing an RCT. And obviously surgeons are always battling fibrosis following surgery. And if radiotherapy does one thing, and one bad thing, it is causing fibrosis. Correct me if I'm wrong. So we do not want to operate more fibrosis than absolutely necessary. So we are just anxiously waiting for absolute proof that it will help, and before that we are afraid that it will cause damage to the tissues that will make it more difficult to operate.
I think it certainly shows good promise, particularly, as you were saying, after the minimally invasive treatments like needle fasciotomy. Jack St. is, I think, a patient who has nodules at the knuckles. Is it common? Yes, certainly. We see nodules at the knuckles very commonly with Dupuytren's disease. Henry Weatherburn, is there a reference available for the radiation risk which you quoted, Richard? So that was the 0.02% for a man of 50 years.
Yeah, so there is a paper by McEwen et al. In 2015 in the British Journal of Radiology. There's a lot of German literature, including in the DEGRO guidelines. I can see that someone else is writing an article by Brurser in 2008. There's plenty of literature out there. I'd be happy to provide some references afterwards.
Fantastic. Maybe we could put some links to those on the symposium website. That would be good. Thank you. Second rounds of radiation. Nancy Gilliam said, at what point should one seek a second round of radiation? Do you ever offer a second round of radiation?
Yeah, great question. So, I mean, just to clarify that we are giving 2 phases of radiation. So that's 15 grain 5 fractions over a week, 3-month gap, and then a second phase of radiation. So that is the standard dose to give 2 phases. But I think what she's referring to is if the patient were to tolerate the first 2 phases well, and then at a later date, they were to have recurrence, let's say new nodular disease or loss of fiber extension or whatever it might be, then can you then give further radiation?
Yeah.
Now there isn't anything in the literature, but certainly there's a lot of experience, including myself, and my own practice is that if the patient tolerated the first treatment well, and there's been at least a year between the treatment and when they re-present, then I will give further radiation. I will try to restrict it to the area where there's recurrence though. So remember, on the first treatment, we try and give a sort of wide field. On the second treatment, we're really just treating the recurrent disease with a reasonably minimal margin. And I would only give 15 grain 5 fractions. So that's just 1 week of treatment rather than the 2 weeks of treatment.
Okay, so slightly more conservative for a retreatment.
Exactly, that's right.
There's a technical question from Michael Eunice, which I'm not sure I quite understand, but I'm going to read it out. Do you use a simple 5mm super flab bolus? Given the varied depth with extensive disease in the PIP and palm, I've used 3D printed modulated bolus. Do you think that that is worth the dosimetry difference?
Okay, I mean, that's a really great question, actually, even though it's a little bit technical. So, I mean, it depends what sort of machine you're using. I these days would tend to use electrons. I used to use kV, orthovoltage, but I don't have that machine at present. So either are absolutely5 both are equally effective. If you're using electrons, I would tend to use 6 MeV. As the energy, and I would tend to use between 5 and 10 millimeters of bolus. It may be that you should vary the bolus on the fingers compared to on the palm, because the thickness of tissue that you're trying to treat on the fingers is very likely to be much thinner. And that, I think, is something that's a very good, you know, a reasonable thing to consider. But most of the time, I would clinically mark the patient up without a planning CT scan. So I tend to use just the same bolus throughout the hand. But I think it's, you know, very reasonable to consider. And a lot of people do much more sort of technical things. You know, a planning CT, sometimes, you know, voluming of the patient and so on. And I think all of these things are very reasonable. But I have to say, I like to keep it simple and not to make it too technical. So that's just my own approach.
Paul?
Richard, I found it interesting what you said about the thickness of Dupatrons. And I'm not sure if that is true, what you say. You said that some people do CT scans or anything else. Do you do that routinely, and do you look at the thickness? Because if you're talking about nodules, then you may be right. But especially in the finger, some parts of the finger can actually be almost half surrounded by Dupuytren tissue, which may make it thicker than the nodule in the palm.
Yeah, so I guess what I'm really referring to in terms of thickness is a combination of both the disease, but also you're trying to go down to the periosteum with radiotherapy. That's really what our aim is. And so, you know, obviously, if you get terribly thick disease, you know, it's something that clinically you can note. I mean, I would say, you know, the way I do it, I tend to probably slightly overtreat rather than undertreat. So,
oops.
We've briefly lost Richard.
Related.
He's back. Great. Sorry, Richard, we lost you. You tend to overtreat rather than undertreat. Yeah,
so the radiation depth that I treat to would probably tend to cover a little bit further than you would expect anyway. And so it would be highly, I mean, when you're treating the feet, I actually think it's a bit more of a question because, you know, that can be very, we can get terribly thick disease. On the hand, of course, you know, you can get quite thick disease, but radiation can treat to any depth. And, you know, the energies and the bolus and, you know, the technical things that we use would tend to probably treat at least as deep as you need. So, you know, I don't, practically, it's not going to be an issue.
Okay. Knuckle pads. Have you ever treated knuckle pads?
Absolutely. So I would treat knuckle pads in a few different circumstances. Quite often, a patient will come with palmar disease, and that's the primary reason I'm treating them. But if they have a painful knuckle pad, I may well extend, you know, let's say I were to go up to the PIP joint in my field. If they've got a knuckle pad, then in order to cover that knuckle pad, I may well extend the field, and I'll be thinking about extending the radiation dose to the back of the hand, to the back of the finger. So I may well increase the depth that I'm treating the patient to in that way. Knuckle pads primarily, I would only really treat them if they're quite tender, you know, or causing problems. You know, I won't just treat a knuckle pad because it's there. I think anecdotally, I would say they sometimes respond and they sometimes don't. That's not very scientific, I know, but that's my experience. And I would tend to use 15 Gray and 5 fractions in 1 week, then reassess. And if they need a second phase, I would do that. But I wouldn't necessarily go to 2 phases automatically.
So it is a potential alternative to surgery for symptomatic knuckle pads.
Yeah.
Because we very occasionally will take them out surgically as well.
Yeah, I mean, I would say that, you know, I've definitely seen quite a number of patients who had a surgical excision with a recurrence who then come to me for radiotherapy, or actually a couple of patients who've had some real problems with the joint for some reason after that, after an excision. And, you know, that has made me go more towards radiotherapy rather than surgery as a result of those patients. I don't know whether that's your experience as well.
Paul, do you want to comment on that?
Yeah, regarding knuckle pads, I'm very hesitant to operate on them because I've seen a lot of very bad results, and I have not operated myself a lot on them, so I'm very hesitant. I don't know whether it's right.
I agree as well, but occasionally a patient is very, very symptomatic from them and kind of almost twists your arm and says, "You've really got to help me."
Yeah, but if a finger thereafter doesn't bend anymore, then I'm not happy, and the patient.
No, and the patient's not happy either, which is the most important. Okay, another question about surgery. Paul, I wonder if you want to answer this. Why is it more difficult to operate on irradiated tissue, or is it more difficult, and if so, why? It's a question from Lisa Lichtenstein.
Well, if I speak from personal experience, I have not operated on many hands that have been radiated because it's not very, very common to apply radiation in my country. But in general, obviously, we do operate every now and then in head and neck cases that have had much higher doses of radiation, obviously, up to 60, 70 Gray. And then we really sometimes run into trouble. So that is probably also apples and pears, but it is the general fear that we get wound disturbances afterwards. The surgery itself is not necessarily more difficult, although you may encounter more fibrosis, as I said before. But as I do not have a lot of experience with it.
Yeah, I guess I would just say that, you know, the likelihood of getting significant fibrosis at 30 Gray would be very, very low. And so I think, you know, I think it's really important to think about, you know, your own personal experience, you know, doing surgery on irradiated tissue, but, you know, we're way below the threshold that you would expect significant fibrosis. So I think it is you know, it's difficult to apply the lessons from high dose radiation in the head and neck region to a much, you know, an intermediate dose radiation in the hand. So, and anecdotally, you know, I have certainly, obviously, you know, you would expect some patients to fail from radiotherapy. And I have sent patients to surgeons to do various things, you know, whether it's minimally invasive or whether it's fasciectomy. And I have to say, I've not, you know, just the feedback that I've had has not been negative. Now, obviously, that is in no way, again, you know, a clear scientific message, but I think the fears may well be overrated. But you know, and I wouldn't expect, you know, from the experience with using these doses to have significant fibrosis, but I can understand why there is a fear, of course.
Yeah, my experience of not very many patients who've had radiotherapy, just a handful, is that it was just like operating on patients who'd not had any radiotherapy at all. It was identical. Marcy Goldsmith is a patient with Dupatrons and Lederhosen and osteoporosis, and her endocrinologist is not keen for radiotherapy for her Dupatrons. Is there an interaction between radiotherapy and osteoporosis, Richard?
Difficult to see how that would impact, and certainly not something that would be an issue from my point of view. Yeah, I'm trying to think if I've missed something, but I don't. It's certainly not something that I would worry about.
Carlos Verdonk picked up on your point about blanching of the palms when you stretch the fingers. Could you just elaborate on that a little bit, and what's causing that?
Well, I guess, you know, the way I think about it is, I guess the skin is being held down by the fibers, and presumably there's an interruption of blood supply to the skin. I guess that's the way I think about it, whether that makes mechanistic sense. What I would say, just I was going to talk about this in my talk, but when I talked about watching and waiting, I guess some of that was sort of implied, but I do a lot of video consultations now. And so, of course, you know, a lot of the time it's very obvious. If someone comes and they've got a clear contracture, then radiation is not appropriate. If they give me a story where they've had nodules and then they've got 3 more nodules and they're feeling some tightness in the finger and you see that they've lost hyperextension, then again, that's very clear. But sometimes, you know, it is quite difficult sometimes to see over the video exactly, you know, you can't feel and you're just seeing. And sometimes that is a very good trick to use, you know, to get them to put their fingers back and to actually see a cord rather than feel a cord. I sometimes find very illuminating. It doesn't always give you the information, but you know, it can be very helpful, I find.
Okay, and one final question. It's back to bones again. Have you ever had any problems with patients healing a fracture, say of a phalanx or of a metacarpal, after they've had radiation treatment?
The answer is no, but whether they would have told me or not is another question. But I wouldn't. No, that's not something I've come across.
Okay, we've just got one more just before we move on to the second part. Lisa Lichtenstein, how can more radiation oncologists be trained in the US to treat Dupatrons? That is a big question.
Well, I think it's a great question, actually. And one thing I would say is that you know, this is a whole discussion about treating non-malignant conditions with radiotherapy. So myself and Professor Siegenschmidt have just started a society looking at this called the International Society for Radiotherapy for Benign Conditions. And you know, our short-term aims are going to be collecting a membership, putting content out there, but our long-term aims really are to have a curriculum and to train radiation oncologists to treat patients both for Dupatrons, Lederhosen, but also for other benign conditions. So, and really we've got probably a 3 to 5 year sort of timeline on that, but that's very much what we're looking to do, because I think that, you know, there is a lack of awareness, a lack of education, and you know, to some extent, you know, even our name tells us that we're cancer doctors. We're radiation oncologists. You know, if we were called radiation specialists, then you know, sometimes words can be very powerful, and perhaps we'd be more inclined to treat non-cancer conditions. But I think, you know, radiotherapy is an incredibly useful tool for non-cancer conditions, you know, so one of my major goals really is to spread that awareness and to train people in the future. So if anyone wants more information, we put a holding website at the moment. It's at isrbc.org. But we'll be sort of formally launching that over the next few months.
I think certainly in the UK we have problems with access to radiotherapy machines in order to deliver this, because there's so much cancer work that it's hard, particularly within our nationalized health service, to justify the benign work. I don't know what you think about that, Richard.
Well, I think that is a good point. So of course this is a limited resource, but not only do we have to think about what resource it uses, we also need to think about what resource it saves. So I mean, if we go off the subject slightly and we talk about, and again, this is a very big complex discussion, but if we think about radiotherapy, let's say for osteoarthritis. So if you get an an elderly patient with osteoarthritis of the hip or knee or fingers and so on, then radiation, in very low doses is an anti-inflammatory, and it may well be that you either delay or prevent the patient from needing a joint replacement or other treatment. So, there's always going to be a cost, but also a benefit. And of course, these discussions need to be balanced in that way. And again, that's one of the things that I think will be very useful going forwards when we talk about the whole area of radiotherapy for benign conditions, which I believe is an incredibly powerful tool that's very much underused.
Yeah, I think you've convinced a lot of us of that as well with your talk tonight. So thank you very much, Richard. You're going to stick around and help us with questions for our free paper speakers.